Good evening. Okay, let's talk about Fogsi endocrine commentary 2020-22 hypothyroidism in pregnancy. The disease burden of hypothyroidism in pregnancy worldwide is 1.5 to 4%. In India is 11%. Okay, and this in India is 11%. So there is a trimester specific TSS cutoff. You have to remember in the first trimester the TSS cutoff upper limit is 2.5 milli international unit per liter. In the second trimester and the third trimester the cutoff is almost same, that is 3 milli international unit per liter. The risk of hypothyroidism in pregnancy, there is a maternal risk and fetal and neonatal risk. In the maternal risk there will be anemia, there will be gestational hypertension, abruption placenta, postpartum hemorrhage and abruptions. In the fetal and neonatal, preterm birth, low birth weight, respiratory distress and neurocognitive impairment. Okay, how to approach to a case of hypothyroidism? You should screen at a first antenatal visit. You have to do pre-T4 level and TSS and pre-T4 level, TSS level and anti-TPO antibody. Okay, if everything pre-T4s and TSS normal and thyroid peroxide antibody is negative, then no treatment is required. Review as when clinically indicated. Then next situation, the second case, T4, pre-T4 and TSS normal, but very important, thyroid peroxide antibody is positive. In that case, you have to observe the patients. You have to monitor the TSH at least once in every trimesters, at least up to the second trimester. So 2 times you have to do a TSS every trimester up to second trimester. Then you can consider low dose levothyroxine in euthyroid pregnant woman who is anti-TPO antibody positive with history of pregnancy loss. Remember when to start if everything is normal except anti-TPO antibody is positive. You can only observe the patient. You can monitor the TSS every trimester up to second trimester, or if she had a history of pregnancy loss with TPO antibody is positive, you can consider to start a low dose of levothyroxine in euthyroid patient women. Okay, the third case, T4 is normal but TSH, if it is the first trimester the cutoff is 2.5 se zyada hai, or if the second or third trimester is cutoff is more than 3. Okay, in that it called as a subclinical hypothyroidism. Okay, in that case what we will do, in case of subclinical cases we have to, if levothyroxine is recommended if TSS is more than 10, or if TSS is 4 to 10 with anti-TPO antibody is positive. Okay, if TSS is directly more than 10, you directly start with levothyroxine. If TSS is 4 to 10 with anti-TPO antibody is positive, you can start levothyroxine is recommended. LT4 can be considered if TSH between 4 to 10, even if anti-TPO is negative. Remember, very important. Patients, you can consider thyroxine hormone if TSH is 4 to 8 milli international unit per liter. Even you done an anti-TPO antibody, if it is negative also you can consider thyroxine. Anti-TPO antibody positive with TSH is between 2.5 to 4. Another things, if TSH is 2.5 to 4 with anti-TPO antibody is positive, then also you can start 50 to 100 microgram per day levothyroxines. Okay, then if free T4 is low, that means what? The hypothyroidism, overt hypothyroidism, TSH is more than 2.5 in first trimester, more than 3 in second and third trimester. Here, irrespective, whatever, if T4 is low, then you directly go for a antibodies, irrespective antibody status, start low dose of levothyroxine, that is 1.6 to 2 microgram per kg per day. 1.6 to 2 microgram per kg per day. Remember this dose. 1.6 to 2 microgram per kg per day. Our target to maintain the TSS has to be less than 2.5 milliliters unit per liter. In patient with, if she had already has a pre-existing hypothyroidism, okay, then you have to increase the levothyroxine dose by 30% as soon as the pregnancy is diagnosed. So remember, if she first time diagnosed overt hypothyroidism in this pregnancy, you have to start levothyroxine. If free T4 is low, very low, then you start 1.6 to 2 microgram per kg per day, irrespective of anti-TPO antibody status. Maintain the target is less than equal to 2.5 milliliters per liters. In patient, if she had already pre-existing hypothyroidism in the pregnancy, before pregnancy, you have to increase the previous dose by 30% as soon as she is diagnosed. Okay. Then how to follow up? You have to do regular TSS monitoring every 4 to 6 weeks until mid gestation, then at least once near 28-week gestation. So every 4 to 6 you will do at least every 4 to 6 until mid gestation, at least once every 20 and near 28-week gestation. You have to adjust the levothyroxine dose as per the TSS. In general what we will do, levothyroxine dose adjustment is 12.5 to 25 microgram per day are made, either up or down depending on whether the TSS is high or low. Okay. The postpartum care, the patient should revert back to pre-pregnant dose of levothyroxine. Suppose your pre-existing dose is 30 microgram, you have to increase in the during pregnancy 30%. So again, she has to come back to the pre-pregnancy levothyroxine dose. You have to recheck the levothyroid test after 6 weeks. Some women who when levothyroxine is initiated during pregnancy may not require levothyroxine postpartum. Those having diagnosis of levothyroxine initiated during pregnancy, they may not require in the postpartum. Such women candidate for discontinuing level, especially if dose is less than 50. If they have a less than 50 microgram daily, if they have diagnosed during the pregnancy and they have taken less than 50 microgram daily, then you can directly stop these drugs. Okay, they may not require in the postpartum period. So you have to recheck after 4-6 weeks, and if anti-TPO antibody is positive, you have to monitor annually TSS level. Okay. Other key practice point, the TPO antibody testing in pregnancy should be done only once. Levothyroxine to be taken 60 minutes before breakfast at bed or at bedtime, that is more than 3 hours after evening meal, for optimal and consistent observations. In hypothyroid women treated with levothyroxine who are planning pregnancy, serum TSS should be evaluated preconceptionally and levothyroxine dose adjust to achieve TSS value between 2.5 reference limit lower than 2.5 milliliters. In patient whom levothyroxine dose requirement is much higher than expected value, evaluation per GI disorder such as H. pylori related gastritis, atrophic gastritis, celiac disease should be considered. Furthermore, if such disorder are detected effectively, re-evaluation of thyroid functions, levothyroxine dose should be recommended. Use of a different levothyroxine product may be associated with serum TSS, altered serum TSS level. A change in blood should be followed by re-evaluation of TSS steady state. Postpartum thyroiditis occur up to 10% all pregnancy, may have a hyperthyroid phase. It may begin from 6 weeks to 6 months post delivery, sometime a year later. It mostly triggered by the miscarriage, occur as early as 6 weeks in women who have a type 1 diabetes are TPO positive. First trimester postpartum depression should be have their TSS monitored 3 to 6 months postpartum. Okay.